District Health. Please note the following for in-person and remote attendees. Please be mindful of your conduct in today's meeting, as this is being recorded and will be made available on our YouTube channel. It looks like we are not accepting public comment during today's live meeting in person. Please refer to the meeting notice and agenda for any questions on that. If you are a remote attendee, please direct any virtual session or Zoom related questions, comments, or concerns to the moderator, myself, in a private message anytime, and I'll be happy to help. Please remember that if you're not directly contributing in the meeting discussion at that time, to please mute your microphone. And if you're experiencing bandwidth issues, please turn off your video feed to preserve bandwidth on today's call. And for those participating within the meeting room, for the board members, please identify yourself prior to speaking and lean towards a microphone. Please remember to click on the microphone button when you're ready to speak, in order to get the clearest audio for our remote viewers joining us this morning. And I believe with that, we can get started today. Thank you.
Okay, we are past the 10 o'clock time to get started, so I will call this meeting to order. This is Commissioner Elliott. To start with, would you please join Commissioner Haynes in the Pledge of Allegiance? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, sir. Okay, I guess a roll call. I see. We'll just start going around that direction. Commissioner Purdy, and then Commissioner Haynes. Here. Commissioner Elliott is here. Commissioner Smith. And Dr. Summers. And then who do we have joining remotely?
I'm on the phone. This is Kelly.
Okay, Kelly. Commissioner Marvin? Nope. Oh, there you go. Well, what did you say he was joining remotely today for? Oh. Yeah, well, you said he was joining that as his camper, and I'm like, oh, okay.
Oh, Commissioner Hannigan's here too.
Okay, thank you, Georgia. I didn't mean to leave you out. I was confused.
That's all right.
All right, thank you. Looking at the agenda, does anyone have any changes to the agenda, any request for additional items? Hearing none, I would stand for a motion to accept the agenda as presented.
Commissioner Haynes, I'll make a motion to accept the agenda as presented.
Okay, second?
Second.
Okay, we have a motion and a second. All in favor say aye.
Aye.
That motion carries. I should ask for nays, but I think I heard everybody. Okay, minutes. We had a pretty good batch of minutes from last meeting. Had a lot of information. Are there any changes to the minutes or additions? Okay, hearing or seeing none. Dr. Smith?
Dr. Summers, I'd like to move their acceptance as presented.
Dr. Smith's my little doctor. Sorry. Barry Swan Smith, I'm sorry, doctor. It just came out. Okay. Well, Barry was a good guy. Okay, I have a motion and a second to approve the minutes. All in favor say aye.
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 Okay, thank you. Motion carries. All right, open discussion. Is there anything that anybody would like to bring up before the board at this time?
This is Commissioner Smith. I wanted to ask, maybe it's just to bust the rumors. The World Health Organization changed the standards for COVID identification through testing. Previously, a doctor used to be able to say this person had COVID and would get on one of the lists for identified patients with COVID. But now you have to have symptoms and a positive test to make the test. And my point is that's why people think that the rate is dropping. It's because of the change in reporting. Is that true for us?
Commissioner Smith, this is Nikki. So weird, but thank you for the question. To my knowledge, and I don't know if there's anybody on our team that's joined, but the reporting requirements for the state of Idaho have not changed. And we have required test results, not a clinical diagnosis, for COVID-19 in Idaho since the beginning. So I don't think we've done any presumptive diagnoses that we would count as a case. And then the only difference would be death, potentially by COVID, is at the determination of the physician, if that goes onto the death certificate or not.
Okay. Dr. Summers, did you have anything else on that? I see you kind of shaking your head, so just in agreement?
I think one of the problems is there's so many different organizations, and the CDC and the WHO try to work together, but things change. They change their definition, they change whatever, and it becomes comparing apples to oranges.
Okay. All right, thank you.
So I have a
yes,
comment
go
on
ahead.
that too. Sorry, Vicki Purdy. In response to that, I guess I have a couple of comments. It's my understanding, yes, that the WHO did do that, but I didn't realize, and the CDC hasn't done that, but the CDC did come out and say that if you didn't have symptoms that you or were considered asymptomatic and you had a test, that you needed to be retested. So assuming that you probably don't have COVID at all because the test results might be wrong because of the cycles, and that's been brought out quite a few times about how many cycles they're using to get a positive test. And speaking to that also, I've had a college coach complain to me about her athletes requiring test after test after test for if they've got two different sports they're in, they're requiring for test after test to go participate, to play, to travel. And I mean, it's just, she related it to a Ponzi scheme, to where, if you don't do this, if you don't take the test, you're forced to not participate or whatever. But at some point, this is getting very costly and probably not necessary. So I just wanted to interject that as we're talking about what we're doing today. I mean, it's time to relax things so that people can start getting back to their normal lives and stop being subjected to all of this nonsense. So if you're sick, you should have a test. If you're not sick, you should not be required to have a test.
Okay, thank you. Anything else in the open discussion?
The other thing, I was just going to add one non-COVID related open
Sure.
discussion.
The whole world doesn't revolve around
I know.
COVID.
Yay.
I mean, it has been for a while, but there's other things
Yeah,
that
there
really
is.
happen in life.
That's awesome. So I just, for the other board members, wanted to give you an update. I've been working with Nikki and her team on some septic permit issues that have been arising. There is new staff in that department, and at least weekly, if not more, have been getting contacted by developers in our county with issues of getting permits. And it's been frustrating for the developers, and I know it's frustrating for our staff here. And so it's something that I think we all need to be aware of and figuring out a good path forward. I had one representative call yesterday and say that Southwest District Health was issuing moratoriums on, septic permits, and Nikki is nodding her head, which is exactly what I did yesterday. It's not true. There's just, new staff that's taking time to review codes and follow them, but, it's a learning curve and it's hard for our constituents, so we'll get through it. So, that's it.
Okay, thank you. Jim County, as you know, is your counterpart on that. Evidently, we have, in places, we have a lot of high water table, and that in itself is a problem, plus, I guess, just the total number of building permits that's being issued, you know, throughout our whole district is phenomenal right now, and I don't know, I guess I would ask Nikki if she thought we had enough people to actually handle the numbers that are being, you know, turned into them.
Mr. Elliott, thank you for that question. Mitch and Jamie will be, well, this is on the agenda later to talk more about the septic system. Jamie and I have been working with staff because we are adding additional staff, particularly, I guess, all of you working in, government understand that we don't want to have, you know, staff around that aren't doing work, and productive, and I think we got a little bit behind as well, so we've had some retirement and staff turnover, so, but with the increasing demand, and basically the increasing staff, like everything I think that definitely has, exponential, growth, in the development area, and we are, definitely
This is the moderator. We're unable to hear you on our end.
You can take your mask off, Mickey, because I can't hear a word you're saying.
Better? Wow. Andrea, you want to get this one away from me? Can you hear me better?
Yes, much better. Thank you.
Okay, I'm going to switch microphones here. So the question that Commissioner Elliott asked was about staffing for land development program. And to just summarize my comments is that, yes, we've had exponential growth in that area and demand for services, and we are staffing up. We are filling some retirements and vacancies, and then adding additional staff this fiscal year, and probably anticipate adding more in the next fiscal year. So we'll be bringing that to the board as we prepare for our budget discussions in the next few months as well.
This is Commissioner Everstreet.
Okay, thank you, Vic. Was that me?
That's me. It's Kelly.
Oh, Kelly, go ahead, Kelly. I'm looking at, wondering whether I'm what I'm doing.
No.
Yes, go ahead, please.
I've talked to Mitch quite a bit about this, and it's not just having the personnel. A lot of it is having trained people that know what they're doing when they go out and do these permits. That's been probably the biggest issue. You can have bodies out there, but if they don't know what they're doing, the body's no good.
Yeah, this is Commissioner Elliott, when I asked if we had enough people, I definitely meant trained personnel or people capable of properly conducting the ground surveys and that. But yes, it is a problem. We've had the same complaints, and I'm sure probably all you commissioners have. I don't think we're unique. Other than that, we've got a lot of high groundwater in places, but as far as the actual number of permits, everybody's got the permits, and it's taking a pretty good chunk of time to get those turned over. And of course, all developers want it done, 84 minutes after they've been in. they can just go out and have lunch and come back and they want it done. And that just doesn't happen. It's not going to happen. But, yeah, I'm glad to hear that there is some action being taken. Hopefully those folks, like you said, are being trained properly so that they can carry out their responsibilities. Is there anything else on the in our open discussion that anybody would like to bring up?
I just have a question. I've had quite a few people asking me about public comment and public participation back in the meeting, and I see you have some chairs back there. I just thought for the people listening, you might clarify, what the plan is to have people come back into the meeting.
Okay, well, I guess right now it's to come back in as long as they can socially distance. I mean, every building, no matter how big, how small, whatever, has a limit as to the number of people that can be there, and especially if we are trying to follow the guidelines from both the state and the CDC. But up until that limit is met, as many people as can come in, whether it's family groups or individuals or whatever, and socially distance, within those groups. There's that many people that can come in. That's my understanding. That's what I asked for last month for this week. So I'm seeing Nikki shaking her head, and that's the way it's set up right now. Now, I did want to bring up, just as a question, a couple of months ago we stopped the actual public testimony, and because of certain things that happened that were just out of line. Don't know that that's going to happen again. We're not in that position right now. My question is that something that the board would like to reinstate as another 10 or 15 minute public input in person here, not just on, through the Survey Monkey? And I'm just putting that out to the board as a question.
This is Commissioner Smith. I would say that I would be supportive of public testimony. I do know what you're talking about and the concerns of that. And so being able to limit that, I think, is important. From a county level, we are also implementing public testimony and even just open public testimony once a month. I think that our constituents, if anything, have learned that local government is the best place for them to have a voice, and I'm all about supporting opportunities for them to give their opinion and be a part of the process.
Thank you very much.
And I certainly support public testimony, but we need to do it better, and we need to truly have a time.
Correct.
This is the moderator. If someone is speaking, we cannot hear you on the remote side.
This summer, I support public testimony, but I think we need to do it better, and I think we need to truly have a timer so
Okay, thank you, sir. Personally, I also support the public being able to, for a small period of time during our meetings, because we have to take care of the other business that needs to take place with the board. But personally, I would like to see that. Any other comments?
I agree. Do you need a motion? Or can you just open it back up?
Well,
I agree with all the comments made from both Commissioner Smith and Dr. Sun.
I would appreciate a motion so that I'm not the dictator.
Okay.
We can't do it.
It's not an action item.
It's not an action item. So I'm just going to do it as the chair for next month.
I mean, yeah.
And if we need something past that, then we'll worry about that as an action item next month.
Okay.
Yeah,
This is
I support
Commissioner
that
Abasturi.
wholeheartedly.
Okay, thank you. Now,
This is Commissioner
time, what do
Abasturi.
we... Yes, Kelly, go ahead.
The chairman of the board is the one that because the chairman of the board is the one that closed off shut off the comments from the public, so it would be the chairman of the board that reinstates the comments from the public.
Okay? Yes, I did. So I
So
will.
that is the proper way of doing that. The
Okay,
board
thank you, Kelly.
the board
Appreciate
can
that.
support that. We can support that through a motion, but it's still you're the one that made that action. So
Okay. All right. Thank you for that correction. Appreciate it. Is there anything else? If not, we'll close our open discussion and go into our introduction of new employees. Anything else that anybody would like to bring up? Okay. All right. Well, thank you very much. We're just a couple of seconds early, but we'll go into the introduction of new employees by the division administrators, whoever they may be.
If Robin or Jamie are speaking, we could not hear you.
Okay, I'm sorry. Can you hear me now?
Yes, you sound great. Thank you.
Okay, thank you. So I have Susanna Gonzalez. She's the newest member to our COVID-19 program, and she is a community health worker, primarily concentrating on the Latinx outreach and the over 65 population. You want to say anything? Okay.
Hi, I'm Susanna. That's all.
Okay, our newest member is Maria Mendoza, and she is a lab tech, and she is primarily working in the COVID-19 testing and the COVID-19 vaccine areas. Maria, would you like to say hi?
Hi, my name is Maria, and I'm excited to start working in the COVID vaccine area. Thanks.
Yes, welcome aboard. Next, is that it? Okay, what did we have that down as an action item for?
I don't know.
Do we have to allow them to come in?
No.
Okay. Well, we are a few minutes early before our next section, which will be the COVID-19 Health Alert Level Review. We're about 10 minutes ahead of schedule. Don't know how people feel about that in the way of Southwest Health District. I know in our own commissioner meetings that we are right on time. We don't do anything ahead of time. We can do it behind, but not ahead, in case there's people that want to participate. So with that, I guess let's open it back up to anything that the commissioners would like to ask that they've been too just thinking about it. Not to put anybody under the bus, but in case there's anything that somebody would like to ask.
I have a question, and maybe this doesn't have anything to do with Southwest District Health, because where I saw it was in Ada County. Some businesses that didn't have mask signs up and weren't forcing you to wear them to come in now suddenly have mask signs up, and when I asked about it, they said they were forced to put them up. Who's behind that? Who's requiring that, and is that going on in our district at all? I mean, it's not in our county, but I'm just wondering.
Hi, Commissioner Purdy. So I can't answer that question for Ada County. I would imagine it might be the city or county code enforcement, but I really don't know the answer to that. And in terms of our district, we're not mandating masks, and it's up to every business to decide how they to make that decision for themselves.
Is there anything else? If not, there's just something I would like to throw out that I've been hearing a lot of lately. I've had sort of some short, very small discussions about the folks. I mean, the people that we represent, and the things that I hear from them, both as a commissioner. I mean, they call me as a commissioner, and I'm, also an electrician, and I go here and there and everywhere, and just, and talk to people. One of the biggest things that I have heard over the last 3 or 4 months, which has tapered off a little bit here lately, but it was brought up again just the other day, vehemently to me, was the contact tracing, and how people feel about that, and how they've been talked to by the folks, telling them exactly what they had to do and couldn't do, and had to do this, and at times, way out of if I will put a big if on that. If I get the story straight as to what they've been told that they can and cannot do, not suggested, and how they have to different family members, how they can or cannot go to school, do this and that and whatever, but it's coming from here. And some of these stories that I've got has been 6-8 weeks, from the time one family member is tested. You can't do this, then you have to wait this long, and then you have to do that, and then you have to, and you have to do it in a very dogmatic, authoritarian way, and those people were not happy about that. And I don't know whether
It seems like we lost audio on the remote end.
Oops. Can you hear that? Oh.
Yes, we can hear that.
Sorry, didn't turn it off. Okay, not that I'm capable of remembering what the last couple of sentences were, but I just said if that was a long time ago we started that. But I mean, if it is a problem, and like I said, I've heard it a lot from different people, different age groups, but mostly the biggest has been people with families. And if it's true, if that's the way that this has been handled, I'm not in favor of it, and they definitely weren't in favor of it. I mean, there was some of those people that were just hostile about the way they felt that they'd been treated. And I mean, if that's true, I'm just saying I think there's something that we need to do about it.
Thank you, Commissioner Elliott, for bringing that to my attention, and Commissioner Smith actually brought one to my attention earlier this week, too, that I had my staff look into. So, having been in our staff's shoes in the past in my early career, part of our job is to slow the spread of disease, and that does involve, when we're talking about a communicable disease, notifying contacts, and also when people are contagious, we want them to isolate themselves and protect others so that others don't get infected, obviously. So how that message is delivered probably depends on person to person, and I would like to say that every time it's a really productive conversation between our staff and the public, but live in reality, I guess, enough to know that that isn't always the case. And certainly I know just from the comments and feedback that I get from our staff doing this work that there are plenty of there are plenty of people from the public that refuse to talk to us and cooperate and be part of that public health effort, I guess. And, you know, there's no consequence to that, and nor should there be, but you know, that's not, you know, we're not going to go, you know, require somebody at this point to be issue a legal order or anything like that. So, but with that said, I also just want to share too, just like Commissioner Smith did earlier this week, if you hear of a situation that concerns you with an interaction between our staff and the public, I'd definitely like to know so that I can, you know, investigate that and, you know, work on doing our job better and ensuring that we're meeting the expectations of the community that we're here to serve and doing so in a respectful, professional way.
Okay.
Commissioner Elliott,
Yes.
I've had similar complaints as well. So that kind of led me, and I haven't read all of it, but page 20, section 065 of the IDAPA code, 16.02.10, I would suggest that everybody get some of that and read it, especially page 20, where we thought that we had the school boards have jurisdiction. Constitutionally, they have jurisdiction over the schools. Rule 05 literally completely takes that away, including private schools, and that it is handed to the Department of Health and Welfare, which, according to the rules in here, Nikki is under the Department of Welfare, and this board really has very little to say about what she does or what the staff does. I mean, we appreciate you listening to us, but according to the rules, we really have nothing to say about it. So that was a huge concern. And then on Rule 09, it talks about quarantine as well. And I guess that probably one of the things that's concerning here is the Division of Public Health Administrator or the Health District Director is empowered whenever a case of any communicable disease occurs in any household or other place within their jurisdiction and in their opinion. Doesn't have any fact base behind it necessarily, not that I'm saying that anybody would do that, but I think that might be happening. And it says, in their opinion, it is necessary that persons residing within must be kept from contact with the public to declare the house, building, apartment, or room a place of quarantine and to require that no persons will leave or enter during the period of quarantine except with specific permission of the issuing order or issuing officer. Orders for quarantine must be executed as described in subsections 065.09A and 065.09B of this rule. So, I mean, that is pretty arbitrary when you're saying in their opinion. So that might have a lot to do with why some of this stuff is happening, and maybe it needs to be changed or clarified.
Thank you, Commissioner Elliott.
Didn't have my mic on.
You want to repeat that?
I guess I didn't have my mic on. Anyway, we are at the 10:40 hour. Now time for Southwest COVID-19 Health Alert Level Review, and I'll turn that time over to Nikki and Rachel.
Thank you, Commissioner Elliott. I will hand over the time to Rachel here in a moment. She has the presentation, but just to put, I guess, this item in context, at the last board meeting, and all prior meetings for some time now, we've been reviewing the health alert levels with the board and having you take action to continue using that process for communicating to the public what the current level of community spread is and the appropriate measures to take to help limit the spread of disease. And there was questions at the last meeting about how that level or how that system was developed. And so hopefully this presentation that Rachel will provide will address your questions. And we're both available, obviously, to answer any questions that might remain following her presentation.
Hi, can you all hear me all right?
Yes, Rachel, we can hear you and see you.
Okay, great.
Yes.
And can we see the presentation all right?
Yes.
Yes.
Perfect. Okay. So as Nikki mentioned, we had some questions at the last board meeting about the health alert levels and some of the metrics we're using. And usually I use this time to review kind of the past month's worth of trends. But we've really been seeing positive trends. We've seen downward trends in cases through all of our counties in our district. All of our counties are currently in the yellow health alert level and are trending towards the gray alert level. So I wanted to take my time today to kind of review some of these metrics, review some of the references that we use to develop them, and just answer any questions, particularly for our new board members who weren't here during the process of developing and approving these metrics. So I will get started on that. So first off, this is our health alert level dashboard. This is on our public facing website. It's kind of towards the bottom. Above this on the website is, more simple graphics that just kind of look at the incidence rate and our mitigation strategies. But we did want this information available if anybody had questions or was curious about it. We wanted it to be available to anyone who wanted to see it. So this dashboard shows our weekly data, 2 weeks worth of data, and we review this each week. So there is some overlap, and that's intentional. That's to provide a more smooth trend and make sure that we have stable trends. This is published each Wednesday on our website, and then Thursdays we'll come out with a news release that recounts all of this information and the decisions. And then, so these graphs here in the gray, those will show you the full year's worth of data. So from March 18th, 2020 to the current day, and that'll show you the trends throughout the pandemic. But then these values here that are color coded on each of these metrics, those are specific to the 2-week date range and the data that we see in that 2 weeks. And that's what we're really looking at when we make these decisions. And all of this stuff is explained here in this blue blurb there, but I don't know if you guys can read that right now. And then we're using qualitative and quantitative data. A lot of our qualitative data is down here in the bottom right corner, looking at input from elected officials, the healthcare industry, educators, and our epidemiologists. And then we also have our qualitative data, which are these metrics and calculations around here on the border. So first we'll look at the daily incidence rate. This is our primary metric, and this typically will correspond with the level that the county has been placed in. So for instance, this is Canyon County's data from last week is what I'll be using as an example. And so last week, Canyon County was in the yellow alert level, and their incidence rate was also in the yellow alert level. There's a few instances where they might not always match up, and I will review that today as well. And we decided to use the incidence rate instead of just the pure case count for that county. And that's just because the incidence rate is standardized by population. So it helps us to compare counties of different sizes. Adams County and Canyon County are very different in size. So if we had 400 cases in Adams County, that would be a really big concern. But in Canyon County, it's putting them in the yellow alert level. But we still do provide the pure case count as well on the dashboard. And our goal with the incidence rate is to have less than 1 daily new case per 10,000 people in that county. You can see Canyon County is pretty close here. Last week, we do have some counties that have reached that this week and are eligible to be placed into the gray alert level. Again, we haven't had this meeting yet this week, but just looking forward, we are seeing that trend into our gray goal level. Next, we'll look at the positivity rate. So this is the percentage of COVID-19 PCR tests that have a positive result. These are averaged over the first week of the 2-week date range, and that's just because of logistics. This data is reported to Department of Health and Welfare, and then they have to determine the county of residence versus the county that the testing facility was in, and they disseminate this information, but usually it's not that week. It's usually the following week. So we don't always have the most recent week of data, but we still have a 7-day average for our positivity rate. And this information qualifies our incidence rate. So this is that situation where the county's level might not necessarily match the incidence rate. And that could happen if we see, a really sharp decline in incidence rate, but then at the same time, a really sharp increase in our positivity rate. That we can infer from that there's a lot of either asymptomatic people or people that are positive and symptomatic but haven't been tested. And so there's no lab report qualifying them as a COVID-19 case, but there are still a number of people in the community that could be infectious and spread the disease. So that's really the only situation where we might see that incidence rate and the county's alert level not always matching. And then our goal for the positivity rate is less than 5%. Canyon County was pretty close last week. I think this week, Gem County was just under 3%. So we're getting to that point, which is really great. Next, we actually have 5 different metrics that I've grouped together. And these are all
Rachel, right?
showing us.
Rachel?
Yes.
I think I missed it, but can you tell me again what qualifies incidence rate means?
Yes, so that would be the positivity rate here. And so that's the percentage of COVID-19 PCR tests that are positive. So with the healthcare capacity, we have these 5 different metrics, and these are showing different aspects.
One more question, Rachel?
Yes.
Okay, so that's positive test. Does it say how many people are actually sick?
Yes, so it'll tell you the number of tests versus the number of negative or total tests, and they do only include individual tests. So if we have people that are tested multiple times in that time frame, they're only counted once.
Rachel, I think what Commissioner Purdy was asking is if they're symptomatic, right? So we wouldn't know the difference in the test when the test is done and we receive it if they were tested and asymptomatically positive or if they were symptomatic.
Yes, that's not reflected in the positivity rate.
And I just want to clarify, so if, I had this question from a coach, so if an athlete is tested over and over and over again because of sports activities that they want to participate in and they're required to be tested for that, does it just comes out as tests? I mean, it looks inflated pretty bad when you see those numbers, but I'm just wondering, do those numbers add to the test numbers? Do they add to the case numbers?
So they don't match
I know that
case
doesn't
numbers. They're only counted once.
Does it come back as the same person being tested that often, I guess? Is that, or is it just tests?
Yes, it's counted by person.
Sense?
Yeah, so it's just
so
if somebody had 5 tests in a week,
okay.
It's just once that they're counted.
Okay, so if one person has 5 tests in a week, it's only one test.
Yes.
But if one person is tested 30 times in 1 month, how is that person counted?
I'm not entirely sure. I know that they are, this is all handled by Department of Health and Welfare, and I know that they are, keeping it to just 1 test per person, so they're not having those repetitive positive or negative tests influence the value. And I can reach out to Health and Welfare and ask them and get an answer for you on that.
Thank you.
Yeah. So for the healthcare capacity, we have these 5 different measures. They're looking at different aspects of our healthcare capacity, which is staffing, which you can see down here, our number of healthcare workers diagnosed with COVID-19. We have supply, which is usually referenced in the healthcare industry input. If we're running low on any PPE supplies, that will be listed there. We have surveillance, which is our emergency department visits for COVID-like illness. This is going to give us more immediate information that doesn't necessarily have to wait for a test or a lab result. This is basically recording the number of times somebody visits the emergency department with concerns of COVID-19. So that's averaged per day. And then also our hospitalization. So that's twofold. We have first the number of inpatient beds, percentage of inpatient beds that are occupied by COVID patients, as well as our hospitalization rate for those patients. And so our goal for the hospitalization rate is less than 5%. And you can see Canyon County was at just over 4%, so they were in the gray level. They met the goal that week. And then our goal in general for these metrics is to preserve our hospital's resources and make sure that we have resources available for our COVID-19 patients as well as people without COVID-19 that still need medical care. Next, we have fatalities. So we use yes.
Rachel, can I ask a question?
Sure.
Was there ever any guidance given to hospitalizations? Because one of the things that I have heard over the last year is the access to health care from individuals without COVID. And so was there anything put out there on hospitals, like we all had to change our business plans. Did hospitals identify and their process for admitting patients with need and how they changed their operations?
I'm
Rachel,
sure they have. I
answer
don't.
that.
Oh, thank you.
So Commissioner Smith, each hospital system is pretty much runs their operations independently, in terms of their business decisions. But they were all required to submit crisis standards of care plans in the state in the event that their systems were overwhelmed. And by and large, I don't know that any hospitals reached to that point in the state. I don't believe any did in the Treasure Valley. Although they came close, but how they kind of managed and avoided that was by reducing their amount of elective procedures. So, and that was a decision, business decision for them to make.
Is it your understanding that most of them are open back up for elective surgeries?
Yes, they are. We get a report every day on the status of the hospitals across the entire state, and all of our hospitals in our district, I think with the exception of 2, and I think they're our rural access hospitals, are all full functioning right now. So that's really great. And the other 2 have some resource limitations, but I think they're also fully, for the most part, operational.
Thank you.
Okay. So for case fatality rate, this is the metric we are using to measure the fatalities from COVID-19. This is similar to our mortality rate, but it doesn't make any assumptions about asymptomatic or undocumented cases. This is purely the number of deaths from COVID-19 out of the total number of cases. This typically doesn't vary, or so far has not varied in any real meaningful way. And that's really just due to the virus itself has not changed up until this point. This metric is very important as we move forward in 2021 as we're monitoring for the presence of some of the new variants, which have been shown to be or can be more deadly. So that's definitely a metric that we'll want to keep an eye on in the next few months. And our goal for the case fatality rate is to have it at lower than 0.5% of the total cases resulting in death. You can see that Canyon County here was at 0.2%, so they met that metric and were in the gray level.
I have 2 questions.
And then, sure.
Rachel, sorry. On this one, does this include people that died from other causes but still tested positive and they didn't? Is there?
No, these are reviewed by Department of Health and Welfare as well as our epidemiologists, and the determinations made by a physician.
Right, but if the physician, if someone died from, let's say, a heart attack and they had COVID, so are they included in this?
If the
number.
physician decided that COVID-19 caused that heart attack. Yeah.
Okay. Okay, and then the second question,
Yes.
I heard that there was legislation, and this is maybe more for Nikki, legislation that's being proposed that creates the standard for a pandemic at 1.5% fatality. So, as a board, what is our option for changing this goal to something else other than 0.5%?
Well, these are what we're using just to really communicate risk to the public and community mitigation measures that we'd recommend depending on the amount of spread and risk for exposure. So we have the flexibility to take input from the board to make changes. I would just say also, though, that there's the World Health, all these other organizations that we talk about that determine, beyond, I mean, we didn't determine there was a pandemic.
Right.
The World Health Organization and the CDC kind of lead the way in that. So how that's defined in other places or even by the state of Idaho might be different, I guess is my point, than what we might designate. So aside from like pandemics, we have, outbreaks or what we also refer to as epidemics in our community that we determine, or in coordination with the state determine. We'll be talking about syphilis later in the agenda, and that's one of those diseases that is nearing that threshold for us. So I don't know if that helps explain.
It does. I would just encourage my stance on this. This is one area as a board I feel like we should consider a change to these metrics. Of course, I only want 0.5% to, this is a great number, but if we're basing the color system on this, tying it to a pandemic, this is a very low number, and we can only be gray when we hit that number, and so as a board, do we agree with that number? And then maybe we even look at some of the other ones. I think that was one of my points of bringing up the health alert system. I did want to learn about it, but I also think that we should have some discussions on what those mean and how they impact. Thank you.
Thanks, Commissioner Smith. I'll just add also that, and I think Rachel mentioned this as well, but we don't make that determination on an alert level with just one point. We look at obviously all these. So
exactly.
Yeah.
Carrie, Commissioners, I want to address that. So there's no way to know for sure what somebody died from unless you do an autopsy. Now, most of the doctors are probably pretty darn good at figuring that out. But when it comes to COVID, there is no symptom that isn't related to COVID. The list is endless. So unless they do an autopsy, they don't know for sure. And that was a huge problem in our county, and some very unhappy family members who a gentleman supposedly tested for COVID after he died of a heart attack. And he had a bad heart, and they knew it, and he'd been doing testing for that heart and had I'm not sure what the name of the procedure is off the top of my head, but he'd had his heart stopped and restarted just recently before that. So he didn't have any symptoms of COVID at all. So then they listed his death as COVID, which gave us our first death in Adams County, which made a lot of people pretty unhappy and very untrusting of this whole thing after that. So that's a big problem, and that's one I've been concerned about, because too many comorbidities of things that other people have probably passed away from are being listed as COVID and inflating the numbers, not to mention the fact that there's a monetary component of that as well. The hospitals, the numbers are on the Becker's list. They're also on another website, talk about the numbers that the hospitals get from a case of COVID, positive case of COVID.
Dr. Summers, my apologies. If you are speaking, we cannot hear you through the remote side.
Maybe you need new batteries too, huh? There might be one. Kelly's over here.
So this is Dr. Summers, and I've talked to several hospital administrators about there's a rumor that they get extra money for COVID, and the answer is no. They get a DRG if they are of Medicare age, and they get so much money. And if a patient is in the hospital for 2 months, they only get so much money. And certainly there's some, shenanigans. I shouldn't say shenanigans, it's not the right word, but they can do some manipulations and some coding changes where that increases their input. But just because they have a diagnosis of COVID, they don't get extra money.
Extra money, but they do get some.
They get paid by a DRG, diagnostic related group. And so if you have a pneumonia, that's part of the DRG.
I get it. The gentleman I was speaking of in my county, the COVID side of it was listed as the last reason for his death. So, but he still had COVID, and would have been a Medicare age, so. Yeah,
and that is, like you said, until you autopsy everybody, you're not going to know. But I have read articles that actually suggest that we are undercoding the number of COVID deaths. I don't know. I don't know.
This is Commissioner Elliott. We're way past our time here already with this. Rachel, can you please continue and finish your report to us?
Sure. So the next 3 metrics here are related to exposure and transmission. First, we have our epidemiologist input here, which will review cluster outbreaks within the county or, exposure modes. We also have our educators input, which will look at cluster outbreaks and transmission within our schools. And then we have the % of cases who can identify a potential exposure source. And this is just looking at, in general, not necessarily cluster outbreaks, but can the individual let our investigators know if they know who they were exposed to? Not necessarily can they give us the name and number of that person, but are they aware, or was it, I just went to the gas station and then I got sick, because that points to community spread. And it's our goal as the COVID-19 response team to work our way back from a place without community transmission. As you can see, we still have quite a bit of community transmission throughout our counties currently. So as I mentioned, we're looking at cluster outbreaks, known exposures, and community transmission. And our goal here is 90% of our cases are traced to a known source. Last week in Canyon County, it was just shy of 62%. So we do have a bit of a ways to go on that metric in particular. And that's, again, an important one because the entire purpose of the health alert levels is to describe the risk of community transmission to our constituents and to our residents in our district. And then we also have the access to testing. As you can see over here, we're explaining the new antigen tests, and then in each county showing the number of facilities and then some of those options that they have if they want a rapid test, if they're asymptomatic, or if they need to be tested over the weekend. More detailed information can be provided by our call center staff, and all of this data is managed by our call center staff. And then I also wanted to maybe just mention the idea of potentially transitioning the access to testing to vaccine access in the coming months as the vaccine's generally available to the public. I think that might be more important information at that time to see the number of facilities offering vaccines and things regarding that. Not proposing any changes just yet. I think we're still a little bit off, a little bit of a ways off from that, but just putting that bug in your ear that we might consider switching to vaccine access instead of testing access in the future. And then our goal for these is just to provide equal access to COVID-19 resources for all of our residents and providing information on where we might be able to provide targeted resources to individuals who might not have those. And then lastly, this is my last slide, but I just wanted to review some of our materials that we referenced when we were designing these metrics. So our alert level metrics were designed by our incident commanders, which includes Nikki and Jamie, our staff epidemiologist, and our resident physician. They had guidance from CDC documents, Idaho State Board of Education, the Nampa Fire Department, and the Harvard Global Health Institute. So these 4 references are on the criteria for movement between the health alert levels document, which is in your board package, as well as your electronic board packet. So you can follow these links and view the documents themselves. These first 2 documents here were published by the CDC in June of 2020, and those are really focused on community mitigation strategies. So you'll see those reflected in our mitigation strategies and some of our recommendations. This third document here is the Idaho Back to School Framework, which was published by the State Board of Education in July of 2020. This was referenced to make sure that we have consistency between the State Board of Education messaging, the messaging from the health department, and make sure that there's consistency between our district as well as the school districts. And then this last document here is Key Metrics for COVID-19 Suppression, which was published by the Harvard Global Health Institute in July of 2020. This document is where we get a lot of our calculations and statistics, as well as some of those levels of, so for example, the percentage of hospitalizations. They've actually done research on what the typical and average number of hospitalizations. If we're seeing higher or lower hospitalizations from there, that's kind of how we're basing our metrics and the movement between those metrics. A lot of that information was provided by that document. So that's all of the slides I have for you guys. So I will open up to questions for myself or for Nikki at this time.
This is Commissioner Smith. Can we ask for ranges for color groups? What the ranges of each of those sections look like?
Those are provided in your board packet. It's in the interim guidance for movement between health alert levels, and it's on pages 4 and 5. It's a big chart. It's like 2 pages long, so I wasn't able to include it in the presentation.
Oh, I see it. Thank you.
Yes.
And Mr. Chairman, what would be the process if we wanted to make, I understand from the last slide, and for the record, this is Commissioner Smith again, I'm sorry, from the last slide, page 9, that it talks about that these health alert levels were designed locally from local incident commanders and epidemiologists. And I'm assuming that our resident physician is Dr. Summers? No? Oh, okay. But what would be the process if we did want to make suggestions on any changes?
Well, if you're asking me, I guess we could make recommendations. However, that decision belongs to Nikki. We as a board, basically the way I are trying to make sure that the monies that our counties expend are being properly utilized. Past that, we do not run this facility. We can make recommendations. We can say things that we agree or disagree with, but in the end, that is the administrator's responsibility. And I guess at some point, if we don't like what the administrator's doing, we start over with a new one. But but in all reality, that is at this time Nikki and her the people that work under her and for her. That is their responsibility. Like I said, but we can make recommendations.
I agree with that, Commissioner Elliott. I do think, though, that making a recommendation specifically tied to that mortality rate, which put us into a pandemic, would be very important. And I would agree.
And where does that come from at the present time? Does that come from the state? Where does that number actually come from? I mean, I don't disagree with you. I think there was a lot of things that were with the pandemic that were politically motivated and not properly thought through. But I would find out first where that number comes from and see what that is. It just something that's out in the air, or does that actually come from the state of Idaho? Does the state of Idaho take it from the CDC? I mean, you know, we're all highly, no, I won't say that. I won't go there with the CDC, so.
Mr. Chairman, this is Kelly. Could I speak for a second?
Yes, sir.
If everyone remembers, we just made recommendations to follow these guidelines simply because we had no idea at the time what was actually going on. Because we were just getting information from the state, from the CDC, and all that. To protect the citizens, these were recommendations that we were going forward with. We know a lot more now than we did then. So, you know, if we want to make different recommendations, we have the right to do that. But again, it's up to Nikki and her staff to make the final, with guidance from the state to make the final.
Okay, thank you. Yes, Nikki?
Well, I agree with Kelly and Carrie. I think this needs to be revised to be changed to the conditions that we have now. Originally, it was meant to make sure our hospitals weren't overrun. Our hospitals were never overrun. So now it's gotten to the point where it's, you know, we're complicit in eliminating our constituents' livelihoods and businesses and family lives and sports and schools. And it's gotten out of hand, and it's looking more like a totalitarianism type situation than it is for the safety of the public. So we need to do something, and if this board has the authority to do that, I think we should be expedient in getting something done so that our folks could get back to business and feel like that they could get back to a normal life. If there's a new strain of COVID, there's a new strain of COVID. We know pretty much how to handle things like that now. So we have to move on. The curve was flattened, I believe, a long time ago.
Thank you.
Mr. Chairman.
Commissioner, yes.
I don't necessarily disagree with the fact that looking at it. My question would be, what's the goal? I'm the pastor of a church. We've been open since this initial 6-week shutdown, and we went off CDC guidance and state guidance. So I know that there's some things, like, for instance, when my children go to school, they go to school 4 days a week. So I know there's been impacts, but if you want to stay open, I don't remember the government shutting us down. Our church has been open for a very long time. So I just want to know what the goal is, because I'm not an expert. I don't know that I should be giving Nikki the guidance on how this system should work. So what's the goal? Why do we need to change it now, would be my question. Not that I'm against changing it. I just would want to know why.
This is Dr. Summers, and I would argue that this needs to come from the state, so the eastern part of the state can talk to the western part of the state, and it's apples to apples. I would also argue, I don't have any problems looking at it, but I don't think anybody on this board, including myself, has the expertise to have the education to really make important decisions regarding this.
I would agree with you, except under the fact, and this is Commissioner Smith, setting a standard for a fatality rate associated with a disease like this, I think is something that we don't need an epidemiologist's background on. That's setting a standard for future pandemics and the right for governments to shut down businesses. Commissioner Haynes, I think that we live in a incredibly amazing district which resulted in hurting families. And specifically, when you take jobs away, you stop putting food on tables, you stop educating our children, and it broadens the divide between the rich and the poor in such a way that there's no comeback for some of these people. And we should not be a part of that. We should be a part of setting a standard that, and we are, going back to what Commissioner Aberstary said, we've learned a lot. And so that's why revisiting it right now when we've learned, and then we might even revisit it again later. We've learned so much. We should set some standards for how we want our community to continue to grow and thrive, because we are setting the stage for additional businesses. There are businesses that are fleeing states. There are businesses that are fleeing cities. And right now is the time for each of us to capitalize on that we are supportive of the whole health of our community and taking that into account. So it's very important to me that I'm a part of a board that is looking at the whole health of a community. And I know that that's what Nikki wants. And so I'm sure that, Nikki, and I'm not putting words in your mouth, I would love for you to comment, but that it would help you if you had direction from the board for some guidance on some of this. And then also I want to quickly note that I'm missing page 2, 4, and 8 in the alert level pages.
This is Commissioner Haynes. I agree with you that, but if, in your own words, this district didn't take those rights away.
Right.
We are only board members of this health district.
Right.
So you and I can't control or have any say over anyone else's health district.
Correct.
So I'm all for looking at it. Don't get me wrong, but I never felt that this board previous to you and I being on here ever took my rights away, or the right for our church to operate or your business to operate.
Right.
So that was my point. Is
Yeah.
we can't dictate what happens at the central health district's meetings, which maybe you and I would say did take some rights away from individuals.
It did. What our local alert levels did, though, and what they're still doing, they're impacting our schools. Our local school boards are heavily relying on these alert levels. And so if they were adjusted in line with what we perceived as a pandemic, I think that we could get schools opened much quicker and our kids back in the activities that they deserve to be in.
Ms. Commissioner Haynes, I completely agree with you, by the way. I would love to have the schools back open as well. I don't want Nikki to spend her time on something that maybe could be spent somewhere else, if a bunch of time, if this is not going to achieve a purpose. That was kind of my comment. But I agree with you in principle 100%.
And my purpose, if we modify those, we can get the schools open back up quicker. I know that many of them are reopening, but I also, if it's not changed and we see some minor increases, I can see the schools pulling the kids out again. And I do not want that to happen. I mean, we've seen, especially in Owyhee County, in the private schools, they are operating, and they are operating fully. And COVID went through the schools, and now it's not coming back. It's good case studies, so that's what I'd like to see.
This is Commissioner Haynes
Nikki?
again. Oh, sorry. I just think that if that's our goal, that's maybe what we should direct Nikki of saying, how do we get our schools back open? Maybe not necessarily, maybe this is the way we do that, but if that's the goal, if that's what we're after, then that's what we should maybe send Nikki and her staff on, is how do we get this open? If it's doing this, that's doing this, but I would maybe direct that question more to Nikki in that regard.
Thank you.
What's our goal?
Yep.
Well, just a couple additions to that. So just the fact that Commissioner Elliott mentions the political side of it, you know, that there was a lot of politics involved. There's still a lot of politics involved. But Commissioner Haynes, it isn't that way. All churches didn't open back up throughout the entire district. There are some that were still too scared to open because they kept looking at the health alerts wherever they were. So the health alerts have created fear where they probably didn't need to do that. So revising them and making them more in line with reality and what we have today, and the fact that we aren't worried about our hospitals being overrun would be extremely valuable to our constituents, and that's our job, is to protect their rights. And they're not all able to exercise their rights because they're scared. They don't all have the same faith that you and I do, maybe, in God, in that sense of the word. So.
Yeah, and this Commissioner Haynes, my comment to be, you're right, there are organizations that haven't opened up, but that's a decision that organization made. You know, my church, for instance, as an organization, made the decision that we were going to open up as soon as we possibly could. So I don't know how much of that we can dictate, you know, of their personal decisions or their organizational decisions.
Yes, Kelly?
Going back to when we first agreed to go to this back in it was first part of August, we were doing this. We put these health alerts out simply to get information to the public. Nothing more. It was not meant to be scare tactics or any of that. It was just to get information to the public. Now, if we need to modify it, I think that's something that the district can look at, and with guidance with Nikki and her group, we can go forward with some other guidance to move this in a different direction. But honestly, all this was about was information to the citizens. So if they were going to an event and it was a highly chance of incident of getting COVID, it was a high risk, and that was the only reason we did this.
This is Commissioner Hannigan, if I may speak.
Yes, go ahead, Georgia.
Excuse me, Fayette County Schools opened with in-class learning months ago. And they've been doing just fine. They looked at the health alerts. They did put a mask mandate in that hadn't been there previously, but as of like last August, September, they've been doing just fine. Just my comment.
Nikki, do you have comment, please?
Elliott. So I appreciate all of the input and stuff. And I do want to point out, too, that I don't think Rachel mentioned this in the presentation. When we presented this to the board initially...
Nikki, my apologies. You're coming through very low.
How about now? Better? Nope. I need a new microphone.
Again?
I don't know. This must be better because I'm hearing myself.
Mm-hmm.
What I was saying was when we first presented this information to the board last year, some of like the Harvard Global, I can't remember exactly who they're called, framework, they kind of had two avenues. One was moving towards suppression, which was basically taking all measures you can to stop the spread of disease, and then more of a mitigation strategy. And we brought to the board a mitigation strategy, not feeling that a suppression strategy was a realistic goal and would have other consequences to public health outside of just the COVID-19. So I do want to just put that out in front of you so that you're aware that what our health alert levels are set at now are probably less stringent than most levels across the country and even across Idaho in terms of what quantifies a level. And so with that said, I certainly, we can look at the mortality rate and bring that, a recommendation back to the board for consideration, whether to change it or not. And Rachel mentioned same kind of thing with like testing and vaccine now that we're seeing some vaccine obviously has an impact in reducing the spread of COVID-19. So I think those are two areas that we could definitely focus on. Dr. Summers mentioned having a standardized process across the state. Unfortunately, when we developed this, or fortunately, I'm not sure how you would take this, but we worked across with the other public health districts and the state to try and implement something statewide, and not everybody was at the same place with doing that, and we just felt a sense of urgency to get communication and information and education out to our community and move forward with what we felt was best. So to step back and try to change that now and to get all 7 districts in the state on board, I don't know if that might be an impossible or daunting task. I'm open to it if that was the board's direction, but I would then have to probably present it in front of 7 other boards to try and make that happen. And then schools reopening, I think that's really good feedback too. We work really closely with our schools, and as several have mentioned, a lot of our schools have been in-person learning for quite some time. Some started in-person learning without mitigation measures really in place, and quickly had some COVID outbreaks that they then shifted gears and put in place mitigation strategies, and have been really successful in holding in-person learning since then. And there's a lot of emerging research that supports that in-person learning can happen with the right safety measures in place. So I think I addressed kind of the overarching feedback, and am happy to work with my team here between now and the next board meeting to bring back a revision for the board to provide feedback on. If there's anything that you think I missed that you want to make sure we consider, I'm happy to jot that down as well.
I appreciate that, Nikki. Thank you.
Okay, thank you. Let us move on. We are very far behind schedule. Probably good questions, good thoughts have been brought out. I will take another 20 seconds and just say, on a personal level, I agree that whatever it is that we're doing as a health district needs to be all avenues or all aspects of health. And yes, and what's been brought up today, I agree with. Not just medically, but everything, I guess, goes to medical at some point, but the way that the kids can grow and develop properly, the isolation that certain people have felt, the things that we have done probably necessarily in a lot of instances have also caused a lot of problems, I think, to the overall personal health of people. And yes, I personally agree that we need to try to get back to those things which allow all aspects of health for people as much as possible. Okay, my 20 seconds are up there. Let's go on to a very short presentation by Mr. Troy Cunningham, who will be in Hawaii again, I'm sure. So I'll turn the time over to Troy.
Good morning, everyone. Yes, I'm in beautiful Hawaii / my office.
I was going to wear my Hawaiian shirt just for that purpose today, but I didn't do it.
Just to join in Hawaii. Well,
That's
good morning,
right.
everyone. I'll make this really, really quick. There's not a lot of change this month from last, so I just wanted to kind of highlight on some of the differences. So if you look in your packets, I believe it's on page 7 of your packets there. If you're looking on the digital version, it's on page 7. I'm not sure what paper page it is. But if you look, so this is our monthly revenue and expenditure report. So at the top in the very upper right, you'll see our target where we should be in both revenues and expenditures is about 58.3%. And so you can see as we go down, we'll use that as kind of our marker. If you look down just a little bit, you can see our total in that same column. You can see our total revenue for January was 934 and our expenditures were 828, which gives us a net cash position in the positive of 105,868, giving us an overall for the fiscal year of a positive 806,673. And just as a reminder, that 806,673 includes some revenues that we received from fiscal year 20 that landed in fiscal year 21. So that'll kind of stay with us throughout the rest of the fiscal year. And then as we approach the end of the fiscal year and look at what we can do with some of that positive cash flow, we'll need to take that into account. I wanted to touch base real quickly on the 105,868. So the reason for that is that we actually had so you remember a few months back, we've had some environments where this is actually the other direction. And some of that was based on kind of the timing of when revenues are paid. So as an example, when we bill the Department of Health and Welfare on many of our sub-grants, most of them are really quick. We had one billing that actually got, I guess, lost, I suppose, on their end. We reached out to them and said, hey, how's this going? So we did get paid from that, and that was a good chunk of money. So good chunk of that net cash position increase in the positive comes from an invoice that was a little bit outstanding from DHW. So it's not completely an accurate picture in our revenues, but as a whole, that is kind of where we stand in our net cash position for the entire fiscal year. Individually, you can see the different levels specific to where they are in fees. So as an example, our fees are at 54%. So these are fees that we receive both in the clinic and environmental health. So those are fees that are charged for different services. So those are just about right on target. This is based on our current budget, our approved budget, and we chatted a little bit about that last month, but this is based on our current budget level. The contract income, that's where we're seeing the largest increase. Obviously, this is hands down all due to COVID. So we have a lot of COVID revenue that we didn't anticipate in our initial budget. So we see that. And then we look at our interest. Our interest is at 17,477. You'll see, nope, sorry, wrong line. So interest is at 15,984. And so our direct total is 69,910. So we're a little behind there, and you'll see that in the following chart that we've actually had a decrease in our in the interest rate, so that has created a little bit of a deficit there. And then we've got carryover funds, and then regarding our so our total monthly revenue is at 68.8%, which is up from 58.3. So again, we're definitely higher than we anticipated in revenue. Then when you look down in the expenditure area, you can see that personnel is at 73% and operating is at 42%. Our capital outlay, make sure I'm on the right line, is at 25%, giving us a total of 59.2, which puts us really close to our target. The challenge here is that if you look at personnel and operating, they're very flipped. Those should be really close to target. And the difference obviously is because of the increased hiring that we've done to manage the COVID response. And based on folks being focused on the COVID response, they're not really working as much in their program and then not creating these operating expenditures. So my goal is, and I'd like to probably present as we get further into the year, I may ask the board for approval to move monies from operating into personnel in the budget. So as an example, our current direct budget for operating is 4.4 million and personnel is 5.9 million. We may look to request some of that in operating to move up into personnel. Typically that's not the right direction. So that's why I want to make sure to put this before the board for approval to move that in that direction. It may come, as we discussed last month, it may also come down to, as we get closer to the end of the year, we may actually have to ask for a budget adjustment where we increase. But at this point, we're still working that we may based on total expenditures, stay really close to target. But again, we won't know that until we get a little closer and further down the road in the year. So that's the summary. Does anyone have any questions so far?
Anyone? Sounds like you must have done a good job.
There we did. Good job. Okay, so I'll move on real quick to the charts, and you can see in the charts how the numbers are represented, and we're a little behind time, so I'll just kind of skip through these real quick. You can kind of see the patterns in both the contracts and the revenues. And then in expenditures, you can see in the personnel and operating, again, for October in personnel, that was a 3 pay period month, so that's why that one looks a little wonky. Operating has been kind of trending up and down, September being a real high month, and January, November, December, and January kind of staying in that same range. Then the last graph is really on our investment yields, and so you can kind of see this is that downward trend in investment interest rates that have then reduced the amount of revenue that we receive from the investments. So that is it in a nutshell. Did anyone have any questions or any additional follow-up?
Anyone? If not, it looks like no. Thank you very much, Troy.
Yes, thank you. And I'll go back to Hawaii.
Okay. Tahiti next time.
Yeah, there you go, Tahiti.
Okay. Okay, on to our syphilis case increase report. Do we have those folks available, or did they give up and go away?
Kirby's on her way, so we'll start in a couple seconds once she gets here. But I'm Kate Lewis, I'm an epidemiologist here. Yeah, we're going to talk to you a little bit about our syphilis situation that we're having. So a little change up from COVID. It might be a nice break. Maybe. Probably one here. Yes. Sounds good. No, I just introduced myself.
Okay.
Yourself now.
Hi, I'm Surbi Malaysia, Program Manager 2 for Clinic Services.
Okay. All right, so we'll go ahead and get started. You can hit the next slide if you'd like. I got you. So just a little bit of a brief understanding of what syphilis is. Syphilis is a sexually transmitted disease that is caused by a bacteria, and we typically see syphilis being contracted person to person through a syphilitic chancre, which is like a lesion that is typically on the genital region, but can also present in someone's mouth and anal region. So going forward, we are looking at an increase in syphilis cases within our health district, and we started to notice this. If you look at that bottom graph, we're starting to notice it in the fall time. So August, September, we're starting to see a pretty good increase from earlier in the year. And then in looking back at previous years, we started to see a pretty drastic increase. So last year we saw about 38 cases. Not about, but we saw 38 cases. And before that, we were seeing in the range of between 14 to 18 cases in a year. So we've over doubled that amount this past year. So also, these are just, this bottom right graph is just showing what we've seen so far this year, which is January and February.
January, we saw 7 cases, but 1 is still under investigation. And currently in this month, we have seen 10 cases with 9 under investigation, 1 that is a true case. Next slide. So just looking at what demographics we're seeing that are presenting with syphilis, we're seeing an age group between 23 to 27 with our highest caseload, but we typically are seeing individuals between 18 and 32 years old that are presenting pretty heavily with syphilis. Now, that's not to say that you can't have syphilis at any age, because we are seeing it between ages 18 to 63 years old. So it definitely doesn't discriminate on age. We do see the occasional congenital syphilis case, and we did see 2 in January, which is of note because we don't typically see a lot of congenital syphilis. And we're seeing it in our white, Hispanic, and non-Hispanic populations generally. Those are really the majority of our cases. Some risk factors that we've noted, a lot of anonymous sex partners, no condom usage, and then sex while intoxicated or high, and then drug use, which typically are including meth or marijuana. Also, if you look to your right, this is at the gender breakdown. We're seeing a majority of our cases in males, so that's just something to keep in mind. Next slide. So with this increase in syphilis, we reached out to IDHW to discuss this surge, and within our discussion with them, we've decided to open up an outbreak so we can monitor the situation. So therefore, outbreak 2021, number 12, and then we've crafted a case definition to include certain cases within that outbreak. So we're looking at cases of early syphilis, which can include different stages, such as primary, secondary, early latent, based off of our CSCE case definitions. And it's got to be among a resident of our district, PhD 3, that appears to have acquired this infection locally. Through our investigations, we kind of can determine that in some fashion. And then any identified contact that they may have had during that infectious period, and that doesn't matter which jurisdiction that they live in. Also, we're looking at cases that were diagnosed after September 2020, because that's when we started to really see our increase. And then also we're examining any congenital cases that we're seeing based off of if there's any information on if that mother had early syphilis. So that's really what we're kind of trying to dive into. Next slide.
So we as a team came up with a response plan, and there are really 4 main categories that we want to define our response under. The first is leadership, interagency collaboration with leadership buy-in, and then provider education, community outreach, and testing. Next slide, please. With intra-agency collaboration, we work with the IDHW to see if the surge qualifies as an outbreak, and that's how we came up with an outbreak definition. We also want to work with Central District Health to collectively respond to this surge, as we see a lot of overlap with close contacts with Central District. And we also want to observe trends for 3 consecutive years from 2020 to 2023 to really determine if this surge is the new normal, because we have seen an influx of population in the Treasure Valley from our neighboring states. Next slide, please. The next thing we want to do is really focus on provider education. We want to develop handouts and posters, and we are working very closely with IDHW to hand us with these materials that providers could use to give to patients or post in rooms that highlights general information on syphilis, as well as health departments will follow up if they do test positive for syphilis. We want to send out health alert networks that are sent out to providers in our jurisdiction that basically reiterates the significance of testing and diagnosing syphilis and reporting that to the health department so that earlier actions can be taken. And we want to develop and distribute an information packet that focuses on the importance of inquiring into patient's sexual history, staging of syphilis disease, and what is the appropriate treatment based on the stages of the disease. Places such as Terry Riley and FMRI, which are federally qualified health centers, urgent cares and emergency rooms. Urgent cares and emergency rooms are
the places where they see the highest volume of syphilis cases. So we really want to target those places because they don't see a lot of syphilis. And we also want to contact infection prevention staff at various hospitals to educate and inform them on disease trends and mitigation strategies. And we do that by quarterly. We have quarterly meetings with West Valley Medical Center, St. Luke's and St. Giles, and so we keep them informed on what we are seeing in our community. Next slide, please. With community outreach, we're looking at collaboration with the community health team that we have here, and they have amazing programs like Cuidate and adolescent pregnancy prevention, but really trying to collaborate with them and also focus on sexually transmitted diseases and use of condoms and signs of syphilis so that people can access care when they start showing symptoms, and also, really focusing on the importance of prenatal care so that we can take care of congenital syphilis. We also want to coordinate with the Hispanic community health worker that we have here at Southwest District Health to target our Hispanic Latino population and educate them on syphilis and safe sex practices. We see a lot of our syphilis clients are in the Hispanic community, and so really targeting that population. And we also want to identify ways through community stakeholders to reach those who don't receive prenatal care and obviously target our congenital syphilis cases, and partner with our nurse family partnerships and parents as teachers programs that we have here in the clinic to target the vulnerable clients they serve who are drug users and things like that. So that's the community outreach, and we've already reached out to the community health team and the nurse family partnerships and are working on a plan together. Next slide. And lastly, we want to increase testing. So the plan is to develop a strike team that will consist of epidemiologists and nurses that perform rapid syphilis testing at high-risk locations such as homeless shelters, addiction centers, to diagnose and treat cases of latent syphilis, link them to care if they do test positive with the rapid testing. And then if we want to train some of our COVID investigators to offer partner services in order to free up epi capacity to do different types of outreach and education. I also want to contact high-risk facilities to a certain testing or coordinate testing with them and provide them with supplies that they need. Next slide. So far we have the accomplishments so far. We definitely worked with IDHW. We got an outbreak number. They did classify this as an outbreak. We also spoke with Central District Health and are working closely with them to see if they're seeing a surge as well at Central District. With provider education, we've spoken at quarterly infection prevention meetings with West Valley and St. Luke's and provided them with what we're seeing in our community. We sent out a health alert network last year and are planning to send one out this year with outbreak numbers. And lastly, the community outreach. As I said, we've already collaborated with our community health team as well as the nurse family partnerships and parents as teachers home visiting programs. So we are really working to try to, respond to the surge and hopefully see some efforts going in the right direction. Any questions?
Apologies, Dr. Smith, we're not able to hear you at this time.
Or caught on prenatal testing or secondary?
We see a lot of primary and secondary syphilis, mostly primary and secondary syphilis. And then we have, I think the two congenital syphilis that we had did not receive prenatal care throughout their pregnancy, and they just showed to, I think they presented to the emergency room with active labor. And that's when they did a syphilis test on them, and they were diagnosed with syphilis. So, yep. Any other questions? Okay. Thank you.
Okay, thank you. Okay. Well, I guess we ought to have a short break, even though we're behind schedule. We'll start up again right at 12 o'clock. Yes, we are. Hello? This is he. We'll get going back now with the subsurface sewage, septic, and appeals process.
So thank you for allowing me to come in today and just talk to you a little bit about our subsurface sewage program, land development. And I know there's been a lot of concern. I mean, this is nothing new. We're just super, super busy, and I'm going to explain some of that to you on like our numbers increased, et cetera. But the first thing that I want to let you know is that we've hired 2 new staff members. We have one that will be starting on March 1st, which is next Monday. And then we also have another one starting on March 8th. So super exciting for us. And I just kind of want to explain that process to you on how we were able to find a couple individuals. We've had the environmental health specialist 1 position advertised for probably a month and a half to 2 months at different time frames, and went through multiple offers with people. I'd probably say I talked to 20 different people on the phone about positions, and then made offers 4 to 5, and was turned down by those individuals. Some of the things that we're running into is that the growth and development in our communities is not only affecting us as a health department and our response time to subsurface sewage applications, but it also, I think, comes into a factor when you're hiring people. They look to come to Idaho and find out that it's actually real expensive to live in Idaho, so the salaries that we can offer sometimes affects us in those aspects. So getting 2 individuals on board is pretty exciting. I think that what we want to do is look for probably another person this coming year, and I'll be able to defend that with some numbers here in just a little bit. And then hopefully leave our budget open for potentially 1 other person next year, maybe 2. I'm going to beg for 1. Ask for 1 and beg for 2. That's what I'll do. And kind of show you some of the reasons why. So also, I know that we talked about this, I don't know, maybe 3 months ago about some sort of internship process, and that Jamie's been working hard on that with Boise State University. There's a few students over there interested in doing some internships. And then also we talked to a professor at BYU in Utah. They have a lot of students that come back here to Idaho that would be interested in potential internships. And one of the things with that school is that they actually have a process in place that when the students graduate from their environmental health program, that they can sit for the REHS exam, which is huge for us, because if they already have that licensure coming in, we can bring them in at more funding, more money, and they already have some of those that information down. So just to kind of give you a little insight on why our program is so crazy, is that since last year, there's been a 38% increase in subsurface sewage applications, or in revenues. So last year, we had an average of about $65,000 per month coming into the program. To date, it's about $87,000 per month. So as you can tell, it's just growing astronomically. And then if we add in the land development program, which is separate from the subsurface sewage, the land development is contractors, subdivisions, milars that come into the organization that we review. We've had about a 45% increase in that program in revenues coming in. In fact, there's more money that came in currently this year than we got all of last year into that program. And what that comes down to is we need just one person that runs that completely, and that's our goal, is that all subdivisions, all city mylars from any county will come to one individual at the Caldwell office who will review those, just so we can get some consistency and that individuals and communities know who they can go to. So that program last year brought in $63,000 the whole year, and currently we're at almost $67,000. So as you can tell, and March, April, May, June, we'll start getting a lot more. It'll probably be about a $100,000 program is what I'm thinking by the end of the year. So it's really just one person that we need to focus on that, especially with subdivisions and that type of development. We really need one individual that's working with all contractors, all engineers, all developers. So also to touch on that, so kind of give you a little insight, like January to February, we've had in subsurface sewage related type activities, we've had 330 separate different contacts. So that could be anywhere from an accessory permit where somebody's trying to add a pole barn, or they're wanting to add a pool to their home, where we just review it and make sure they don't encroach upon their drain fields or their primary or their secondary drain fields, to full out subsurface sewage applications. What that comes down to is about 10 in Adams and 10 in Washington in our contacts in counties. We discussed that at one of our meetings, not having somebody specifically being in Adams County at all times, just due to the fact that they can go up there probably 1 to 2 days a week and do Adams and Washington County. I mean, of course, we know this is a slow time of year. January, February is not a huge growth up there. And it'll pick up, we know that. But I think that we can still do that and provide a lot better service, a lot better quality. So with Canyon County, of course, it's always the biggest, 183 contacts just since January 1st. You know, they're more than all other areas put together. Jim County would be the next biggest, 52, 48 contacts for Payette County, because it's really starting to pick up in growth there, and then 24 with Hawaii County. So, yeah. No, we didn't. I wish we could, but we don't. So, if it would just help us slow down, we'd be so happy. So, I don't think Nikki would let us do that. Anyways, yeah. That's right. Yeah, hold on, Gary. So, another thing that's happened is, that's been really beneficial for us, is that Canyon County's been sending us weekly reports of applications that are coming through them. The other counties, I don't think, have this process, but I'm sure we could work with them on it. But just kind of to give you an insight, in this month, the 1st through the 5th, they had 26 different applications come through. The 8th through the 17th, or 8th through the 12th, there were 17. And then the 15th through the 19th, there was 30. So 56, 60, 73 some just applications from Canyon County alone in 3 weeks. When it comes through them, we have some sort of process that's in that, or down the road in that, due to the fact that it could just be, again, it could be a full application, it could be something with land development, or even just an accessory type permit. So a couple of the things that we're trying to do is, or at least one of the big things, is we're working on an electronic database right now through our hedgerow database that we use to put subsurface sewage applications into, and also food applications. They're coming up with an electronic database where somebody anywhere will be able to enter in their information and directly upload into the system. And then that'll be something that can just be sent to an inspector, and they can go out and conduct the process of an inspection or accessory use permit. It's going to be extremely helpful. It's just because the front office, once they get that application, a lot of times they're calling people back, trying to get information that's been missed. You know, this process will be, they can't miss anything, they got to go through it all, uploading the parcel piece, and then they'll also be able to pay right then online, which, you know, instead of our staff going back and calling and getting payment, Olivia's stacks on her desk sometimes are like this, and it takes her weeks and just enter applications and then for us to go out. So it's going to be a little bit of a cost to us, but the program can support it, and I think it'll save money in the end. That's what it'll come down to. So I think along with that, just kind of gives you an overview of what's going on with the subsurface sewage program, and it's continuing to grow. And I'll provide you numbers monthly if you'd like them. We can do that. I know that there was a request on appeals process. So the subsurface sewage, there's two different appeals processes in our SOPs. And the one that we use is the 410801 appeals process. And all districts use that except for District 1, and they use a statute. And I'm not sure why they do it. It seems to be more monotonous to me because it goes pretty much appeal to district court, which seems a lot of work. And so our process is if somebody has an egregious, complaint against one of our staff members, they can file in writing. They have up to 35 days from the decision that our staff member has made. They'll appeal to a supervisor or director, or division director, and then we have the opportunity to invite them in for a meeting, and we can do, I believe it's a 10-minute presentation by the staff member, the person who feels that the decision made was egregious or against them. And these type of decisions have to be something that's like breaking a rule, a policy, a regulation. It can't just be like, I want a system because I want it. It has to be something that a staff member's done to affect them while following a rule, policy, or regulation, or they broke the rule, policy, regulation. And then we have 5 days from that time frame to provide a written, response back to them. Honestly, most of the times when somebody has a complaint, they'll just call up, they'll talk to me. If anything, it maybe gets elevated to Jamie, but most of the time we can internally just talk about it. However, if they want to go through that process, we provide them those options. And how that works is actually, so if a citizen had a complaint on a staff member, it would go to me or Jamie. If they didn't like what Jamie and my decision is, they would go to Nikki. If they didn't like what Nikki's decision was, they could actually come to the Board of Health. And if they didn't like what the Board of Health decision was, they could actually take it to district court. So I don't think I've ever heard of it going that far. So that's kind of the appeals process we use. Now, there is also an appeals type process, and it's more like a variant procedure. Say if somebody disagrees with how we've written a permit or not written a permit for a system, or said you can't have a system, that individual can email Department of Environmental Quality, the on-site wastewater coordinator. We would provide our findings on to DEQ, and this person could provide their insight on why they feel this is egregious, and DEQ could make a ruling on that. I would honestly say that DEQ is probably not going to go against the health department, but they can. And the reason why is because the big manuals that we use, the technical guidance manuals, we follow them, which are rules from DEQ. So we're hopefully that we're doing it right, and we don't have to worry about that. But there is always that option, and we have allowed people to go to DEQ in the last 2 or 3 months. We've had, I think, 2 that have sent their requests onto DEQ and asked for an approval or a change in what our ruling was. The DEQ rolled with what the health district had put in place. Any questions on that? I know that didn't quite take 30 minutes, but I think I'm helping you guys speed up. And I know we've had some talks with some installers lately of more or less some complaints on staff members on how they're going about the process. One recently that talked to me about, wanted to know why we came out and did a trench inspection, when in the past we just took pictures and sent it in. And, it's more or less we explained to him it's just what happens in technical guidance manuals, what's required of us. If we do a cap and fill type system, we have to go out and do a trench inspection. And the response that I got from the installer was, well, that's why I quit working in Ada County, because they followed the rules. And so I think we're okay, because we're following the rules is what it's really coming down to. And they said that's why we don't cross the border. We want to continue to work over here, but we really have to follow those rules. We can't, just make our own guidance, our own processes.
So is that because you're holding people up from continuing to work? Because if you're doing a trench inspection and they dig the trench on Monday and you don't get to New Meadows till Friday, you're holding them up for a whole week.
Yeah, that could be the process of holding up right now, but that's what we're trying to do right now, is to get more staff on. So have people that are dedicated just to those counties so they can be up there that week. And there's sometimes with
the building window in New Meadows is incredibly short. Like, we have 4 feet of snow right now. You won't be able to build for won't be able to start for quite a while, and then you may have till the end of October, and you may not.
Absolutely. So, we hope that our process of having an individual that's just dedicated to subsurface sewage in Adams County and Washington County is gonna work out. We will, come back and reevaluate it if we seem to have struggles. So please keep us informed on that if you're hearing anything. But like you said, right now, there's not much we can do. The snow is over 6 inches, and our SOP actually says we shouldn't do any type of test holes even over 6 inches. And some of our staff, because it's not a technical guidance manual, but it's just a operating process, they'll still do test holes with 6 inches of snow. But when it comes to doing a final, they wouldn't, because they couldn't be able to find out where the water was at, the wells, et cetera, the waterways.
Chairman Elliott, may I ask a question?
Yes, go ahead.
This is Commissioner Smith. This is not a trick question, and I do not know the answer to it.
That's it.
For the smaller counties, is it possible to set up a program where you could designate someone that lives in that community that didn't install it to do a check on behalf of the district, or?
I just don't think that would be it sounds good, but I just don't think that would be a good process, and plus not being a registered environmental health specialist, having their licensures on the line, because in the end, that person's going to sign off on it. And I understand, I wouldn't want to sign off on something that somebody else looked at. There's quite a 400 or 500 page manual that we follow, and I think it'd be hard to find somebody that could do that. So it sounds great. We hope we can just get. I think our biggest problem is just staffing. We just got to find staff. We got to find people that can work in this program. We got to know the appropriate salary for these individuals to do this.
It'd be really cool if you could find retired environmentalists that live, and because they do like to retire in those areas, that might be interested in part-time work.
And that's something, if we had somebody who had that REHS licensure, had it up to date, that is an option, I would think. It's just finding a general, person on the street and have them go out and try to do that. I think we would be asking.
I was not implying a general person on the street, just
yeah.
so you know, not at all would I ever suggest that.
And it's really hard to find REHS staff. It's super hard. It's not something that people come out of college with that certification already, and once they get it, they need to be trained and go through some onboarding before they get their licensure and then become registered. So I wish it was. And I worked in community health for years, as you might know. I never had a problem finding somebody to hire. And I come over to this field, and I'm like, wow, what did I step into? Because it's really hard to find people and find quality people. I don't want to just hire somebody to fill a spot, because that's just going to provide more trouble down the road for all of us, and it'll probably make contractors way more mad and installers way more mad. So I can promise that when we find these people, they're going to be quality individuals, and they're going to help us out. And I'll try to keep the complaints down for the commissioners. That should be my number one goal, right?
We would appreciate that.
Thank you all.
Yeah.
I'll do as much as possible.
Of course, if Commissioner Smith would just slow down the growth in this county, the rest of us could get done quickly.
The moratorium.
Thought about it. Well, no, because then all of them would just move over to him. No, just slow it down, that's all. Anyway.
And we appreciate Commissioner Smith's help already. You've connected us with development services, and we've got some things figured out. And think we're working some processes out.
Is that all, sir?
It is.
Is there any questions from commissioners, near and far? Okay, I'm not hearing any, so thank you very much.
Thank you.
It definitely is a ongoing concern, because we're not going to slow down from getting people coming here, at least not for a while. Okay, thank you, sir. Okay, sounds like Mr. Troy is back up again for approval of the Swigert and John Associates audit report.
Good afternoon, everyone, again. I just wanted to kind of circle back. I believe this was on the agenda from our last board meeting. So if you remember, we met with Jordan Swigert, who is our current auditor from Swigert and Associates, and he presented the audit report as it was, and it just wasn't on the agenda last time to be approved. It just wasn't informational, so we put it on agenda to be approved, just so that we could circle back and tie the knot on that one. I'm not certain. I can certainly bring it back up if anyone wants to review it, or if we just wanted to go and approve what we heard last time.
Any questions, commissioners? Would you like that brought back up, or are you ready for, are we ready for a motion to approve that? Go ahead. Yes, ma'am.
I would make a motion to approve the audit report.
Okay.
I'll second that.
We have a motion and a second, all in favor of approving the Swigert and John Associates audit report. I don't remember the dates.
Was fiscal years 18 and 19.
Was it 2017 and 18?
For
No,
fiscal
sir,
year, correct?
Yes, sir. It's fiscal year 18 and 19.
Okay. All right. Thank you, sir. I just want to make sure we get that in the minutes. Okay, I have a motion and a second. All in favor of that approval, say aye.
Aye.
Aye. Any nays? Hearing none, that motion carries. Thank you very much.
Thank you very much.
We'll go on to, I don't know, there was some discussion there. Do you want to go ahead with that, Nikki, or put it all in? No, I think we better do it for informational outside of the executive session. Okay, so IADBH Executive Council update. Turn that time over to Georgia and Nikki.
If anybody's been paying any attention, there's a couple of fire hoses out there and things are moving at the speed of light. There's Senate Bill 1060 that has, I think, moved out of committee, and I think it's out of committee. Am I right, Nikki? And that is the bill that changes the funding for health districts in the interest of Medicaid expansion. And I'm sorry, I'm not speaking well. I had surgery yesterday and tubed down my throat. So what it does is it takes the state out of funding health districts, removes medical indigency responsibility from the counties, and turns the responsibility of the health districts over to the counties. And that brings lots of questions. Then, what is the county's relationship to health and welfare? What's their relationship to DEQ? What kind of contracts then do we have to enter in on our own? And how do we coordinate this with all the 7 districts?
Georgia?
Yes.
I'm going to slow you down there a little bit. If that has not been printed yet, we'll bring that up in our executive session.
Okay, I will say Seth put it out this morning.
Oh, was it printed out? Okay.
Well, Seth sent it out to all of the commissioners this morning.
Okay, I don't know what to say now.
Well, like I said.
Okay, all right.
I don't think it's out of print hearing.
Out of what?
I don't think it's out of print hearing. I think it's...
Because it had a print hearing.
That I'll have Nikki respond.
Okay, I'll ask her. She just told me.
Okay.
Commissioner Hannigan, I don't think it's had a print hearing, only because we're supposed to have...
Nikki, we're having issues hearing you again. My apologies.
Oh, and you just fixed that.
Is this better?
Yep, it is.
Absolutely, thank you.
Okay. Yes, thank you. So Commissioner Hannigan, I think that is still draft legislation, only because we're supposed to meet at 3 o'clock to review it with IEC and the Executive Council and our
Okay.
lobbyists. So,
All right, my apologies. I've just seen it from several
no, that's
sources
okay.
now.
Yeah, it gets confusing. So I think the only other update that the Executive Council had been working on or had been involved in primarily was the Senate Bill 1060, I think. Does that sound right, Georgia?
Yes.
Okay, yeah. And I think it was supposed to be heard today, actually, on the House side of Health and Welfare. And then there's also some draft legislation to restrict public health districts and health and welfare from school closures, which we're not taking any action or weighing in on, from what I believe to be correct. Is that also your understanding, Georgia?
Yes.
There are a couple different bills, and I think they're primarily coming out of the Senate side. And it would just, so currently there's, public health districts have the authority and health and welfare to close a school because of a public health threat. To my knowledge, that's never been done in Idaho. Usually, at least in my experience, the schools decide to close before public health would say it's appropriate to do so, or necessary maybe to do so. But there's some legislation introduced just to take that authority away from us and give it to the school districts to make the decision on.
Commissioner Smith, Chairman Elliott, is it okay if I speak? Isn't it true that the State Department of Ed closed the schools, not any health district? Because they closed them last March, right before spring break, and that came from the State Department of Ed, not any of us. Just for the record, trying to clear that up.
Yeah, that's a good question. That was so long ago now, I don't remember. I know it was not the public health districts.
Right.
Or the Department of Health and Welfare. Right. And similar to, like, we were talking earlier about our health alert levels, which the Department of Ed also put out their own alert levels, which kind of confused a lot of people between what the public health districts had done and the school Department of Ed had done. So we did try to crosswalk that for the schools in our district, but it's kind of a side note.
Yeah.
Commissioner Elliott, Commissioner Smith, they added that to IDAPA on 3/20/20. So it actually says, and that was the same page that I was referring to earlier on the orders for quarantine, it actually says, the director may order the closing of any public, parochial, or private or other place of public assembly when, in their opinion, such closing is necessary to protect public health. The school or other place of public assembly must not reopen until permitted by the health official. So that's Rule 005 point.
Okay. Back to the council update.
I don't have anything more to add on that, on the informational piece. Commissioner Hannigan, do you have anything else to add?
No, not at this time, thank you.
Okay. All right, thank you very much. With that, then, we'll go on to the director's report.
Thank you, Commissioner Elliott. So I'll just run through these really quick in the interest of time. First, I don't have it on here, but it's an announcement. Dr. Roscoe has accepted, I won't say new position, well, I guess it's a new position within one of his current employers. So this is his last board meeting. with us, and we are in, I guess you could say, I wouldn't maybe say negotiations, but I'm preparing an offer letter for a new medical director. Hope to have him on board by the end of the week and be able to introduce him at our next board meeting. I have a legislative update. I won't go through that, but it's in the board binder for your reference. And if you have questions, feel free to reach out to me offline. The annual Idaho Association of District Boards of Health meeting will be held on June 17th. It's usually 2 days, but they are shortening it because some of the boards had a preference for a virtual meeting and some wanted to do in person. So there's going to be a mix of in-person or virtual depending on the board's or the board member's preference. And that if you do want to attend in person, I think it'll be in Twin Falls. Some more information to come on that. The executive council and trustees often meet prior to the full business meeting, but I don't have final information on that yet for you, Commissioner Hannigan, but I'll let you know. And then there has been some conversation. I think there was conversation in the last board meeting from board members and I think some prior board meetings too. And I just wanted to provide an update on our contracts listing. There's been some expressed interest in just understanding which contracts we have, and so we have that document about ready, but it wasn't ready for prime time today. So we will plan to share that with the board at the next meeting. And that's the end of my director's update.
Okay. Any questions for Nikki on any of those? Okay. If not, then we need to go into executive session. Idaho Code 74-2061D. We will do this one first, and then we have another executive session afterwards. So, polling, I would make a motion, that we go into executive session 74-2061D.
Does that cover, like, public records exempt from disclosure? That's, oh, luck.
Okay, do I have a, well, the things we discussed there need to be pursuant to that.
Right.
Do I have a second?
Second.
Okay, thank you. Polling of the commissioners. Commissioner Hannigan?
Aye.
Aye.
Okay, now, are we selectively in?
So when you all vote, then Ashley's going to move us into a breakout session.
Okay. Okay. All right, very good. I just want to make sure we're doing the right thing here. Okay, let's see. Commissioner Haynes.
Aye.
Commissioner Smith.
Aye.
Commissioner Aberstary.
Aye.
Aye.
Commissioner Purdy.
Aye.
Commissioner, Dr. Summers.
Aye.
And Commissioner Elliott, aye. Okay, we are now in executive session at 12:35.
Just a moment. So we have opened the rooms for the shift there. All right. All right, and at this time, the board members are in executive session. We will resume the meeting after that.
Okay.
I thought it was just me that couldn't read.
Nope. Ashley, can you hear us?
Yes, so we are back.
Okay, thank you.
Now that we're back, we're going to go out again here real shortly. Okay, now that we're back, I would make a motion that we go into an executive session, Idaho Code 74-206 1B.
Second.
Okay, I have a second. Poll of the board members. Commissioner Hannigan? Maybe we lost her in the changeover. She is muted.
I'm trying, okay, aye.
Okay. Polling of the commissioners to go back into executive session, 74-206 1B. So we have a motion and a second. We were asking for a poll of the commissioners for that. So, Commissioner Hannigan.
Aye.
Guess that was a yes? Aye, okay. Commissioner Haynes.
Aye.
Commissioner Smith.
Aye.
Commissioner Abersturi.
Aye.
Commissioner Purdy.
Aye.
Dr. Summers.
Aye.
And Commissioner Elliott. Aye. We are now in executive session at 12:56. Okay, so we'll wait a minute.
All right, at this time we are transitioning to the executive session. All right, and we are back. We can see you now.
Okay, very good. Is there anything else that needs to be brought up at this board meeting? If not, I'll wait for a couple seconds. Time's up. We're dismissed.
Wonderful,
like I
thank
ate
you. We'll
enough
be
snacks, I
closing
don't
the
need lunch
live stream now.
Thank you.